It gives me great pleasure to introduce our speaker of today. Professor Marwan Abouammoh is well known to all of us. Professor Marwan is a full professor at the King Saud University, Department of Ophthalmology, and the head of the research committee in the department. He has numerous publications and has written multiple book chapters in various topics in retina, medical retina, surgical retina, and ocular inflammation and uveitis. His lecture today will be on intraocular foreign bodies. I will open the mic for Professor Marwan and welcome him for his lecture.
So, Bismillah ar-Rahman ar-Rahim. Our lecture, our grand round today is titled Intraocular foreign bodies, update on clinical characteristics and outcome. The objectives of this presentation is to understand the ocular trauma terminology, to recognize the common clinical characteristics of intraocular foreign bodies, to know the clinical characteristics and risk factors that may affect the final outcome, and to be acquainted with the current known status of intraocular foreign body injuries, ocular injuries in the country. So ocular trauma is an important cause of preventable visual impairment worldwide. And to describe the ocular trauma, we go by the Birmingham eye trauma terminology. The intraocular foreign bodies or retained foreign objects are a subset of penetrating injuries when there is an entrance wound without an exit wound. When there was an exit wound, we refer to it as perforating injuries. The previously reported incidence of intraocular foreign body ranges from 18% to 41%. The largest series is by Zhang from China, and it included 1,421 eyes, and the incidence of intraocular foreign bodies in this study was around 29%. Usually the gender is there's a male majority when it comes to the gender affected by intraocular foreign bodies. Even 2 studies or even 3 studies actually reported that all patients were male that were affected with the intraocular foreign bodies. The nature of intraocular foreign bodies are usually metallic overall, and in the pediatric population, it has been found that pencils were a majority in a study published from China. Another study from China by Yang and his colleagues reported that fireworks were the most common intraocular foreign bodies. The study by Zhang reported that the second most common intraocular foreign bodies were fireworks. So these 2 studies almost are similar. But they also reported that children that are left behind unattended after intraocular foreign body injuries had a worse prognosis. The mechanism of foreign body injuries and ocular foreign body injuries is usually hammering. And the only 2 studies reported that grass trimming was a cause of intraocular foreign body. Those 2 studies come from Southeast Asia, namely from Singapore and Taiwan. The sharper the intraocular foreign body, the deeper the penetration, regardless of the mass. But if the mass is greater, it means more or worse visual outcomes overall because of the higher inner energy that is accompanied by the higher mass of the foreign body. Just to remind you, these are the zones of injury. So you have zone 1 localized to the cornea up to the limbus. Then you have zone 2 extending till 5 millimeter behind the limbus, and zone 3 posterior to that. So it has been found that the entry was usually in zone 1 across all studies, followed by zone 2, then zone 3. And the site of impact, or where the intraocular foreign body settles, was usually intraretinal in 30% of the patients in one study from France. It is usually in the posterior segment overall, whether the vitreous or the retina. One study reported that it has been found that the anterior segment was the most common site of the intraocular foreign body. Of note, this study had just immediately after the anterior segment as a common cause of intraocular foreign body settlement is the posterior segment by 44%. So it's almost similar. The factors affecting the final outcome of intraocular foreign body injuries are interconnected and related to each other. And each factor affects the others in different ways, whether in a good way or a bad way for the final outcome. So we start with presenting visual acuity. So as you all know, poor visual acuity will, in presenting visual acuity, will definitely mean a worse final outcome. This has been found across all studies, including a study from King Khaled Eye Specialist Hospital by Dr. Chowdhury. Only one study, which included a very small number of patients, mentioned that initial visual acuity is not correlated to the final visual acuity. As for the site of intraocular body, we are talking about two things: the entry site and the impact site. So the scleral entry, or a corneoscleral entry, was found to have a better prognosis than a clear corneal entry. Probably this is because you salvage the cornea, so the optical properties of the cornea are maintained. A study from King Abdulaziz University Hospital found that the corneoscleral entry site had worse visual acuity outcome. And in this study, obviously, the cornea is affected, and thus the optical properties are not as optimal. The posterior intraocular body was associated with worse long-term visual outcome across many studies, including the one by Zhang, which included the highest number of patients with intraocular foreign bodies. Only one study that mentioned that the entry site had no association with final visual acuity. And in this study in particular, the majority, more than 3/4 of the patients, had a corneoscleral entry wound. As for the size of the intraocular body, you have either the size of the foreign body itself or the size of the wound. And each have its relation to the final outcome. The wound length of at least 3 millimeter and an intraocular body location located in the posterior segment was found to have a bad outcome. So the bigger the wound, the worse the outcome. And it has been found also that an entrance wound that is larger than the largest foreign body diameter meant worse outcome. This can be explained by that the foreign body has a higher mass, and thus it has a higher energy impact on the ocular wall, and thus it ruptured the anterior ocular wall, and thus the wound is larger than the foreign body. And obviously, the larger the foreign body, the worse the outcome. Liu et al. Found that a smaller intraocular body size was associated with good visual acuity. And only 2 studies found that the size had no relation to the final visual acuity. In those 2 studies, they only included 31 and 57 patients each. As for retinal detachment, it has been found that there is a risk up to 30% of post-operative retinal detachment after primary repair. It has been also found that initial retinal detachment was associated with worse prognosis, visually and structurally. There was a higher risk of retinal detachment with posterior segment intraocular foreign bodies and with posterior entry sites. This fact is both at presentation and post-primary repair. And it also has been found that endophthalmitis and retinal impact sites were risk factors for developing rheumatologic retinal detachment. As I told you, that the factors related to the intraocular foreign body injury are interrelated. So a wound length with 3 millimeters or more was found to have a high risk of retinal detachment. And it has been found that delaying the extraction of the foreign body, or the presence of dense intraocular hemorrhage, and the primary surgical repair combined with intraocular body removal at the same time were predictive factors for anatomic failure of RRD repair. So this might deter you from removing the intraocular body at the time of presentation with open globe injury. It also has been found that the large intraocular foreign body and endophthalmitis were risk factors, obviously, for developing rheumatologic retinal detachment if not treated early. And it has been found that the main post-operative complication after retinal detachment repair was PVR-associated recurrence of the retinal detachment. As for endophthalmitis, this patient presented to the emergency around 3 or 4 weeks ago with primary repair done elsewhere, and on the 3rd day he developed this picture of endophthalmitis, and unfortunately the cornea was too bad to undergo vitrectomy. So factors related to the development of endophthalmitis includes lens capsule rupture, primary repair more than 24 hours, removal of the foreign body more than 24 hours after trauma, and not injecting intravitreal antibiotics for susceptible cases. Obviously, the removal of intraocular body later than 24 hours after trauma is the usual way we go. As primary repair is done, then the patient is referred for intraocular foreign body removal. So Liang obviously is advising for early removal. Older age, intravitreal antibiotics, intravitreal foreign bodies and plant or metallic foreign bodies meant higher risk of endophthalmitis in a study by Duan. And for the pediatric age group in a Chinese study, they found that actually metallic foreign bodies and intraocular hemorrhage meant a low risk of endophthalmitis, while zone 2 injury, which is scleral or conioscleral, and traumatic lens rupture were associated with a higher risk of endophthalmitis. It is a serious complication, as culture-positive endophthalmitis were identified more in open globe injuries that had a concurrent foreign body compared to other open globe injuries with endophthalmitis. And Park and colleagues found that the vegetable matter exposure and delay to initial management, that is primary repair and intravitreal antibiotics in susceptible cases, were associated with a high risk of endophthalmitis. Thus, Jonas advised for removing of the foreign body within the first 24 hours, as this may reduce the risk of infectious endophthalmitis and proliferative retinopathy. While Yang found that there is no association between time interval and foreign body removal and the development of foreign body removal and the development of endophthalmitis, as he advises for primary repair, then proper assessment of the patient, putting a plan for removal of the foreign body, and then carrying on the procedure. In the largest study by Zhang, largest study that included intraocular foreign body, they found that primary repair within 24 hours, only primary repair, not removal, only primary repair within 24 hours, and self-sealing wounds were associated with lower risk of endophthalmitis. The self-sealing wound effect of lowering the risk of endophthalmitis can be explained by the fact that the eye is no longer open and thus it is not exposed to the outside environment. Yang found that, again, delay in primary repair would increase the risk of endophthalmitis, as we all agreed on now. Chowdhury from Kekesh also found that delayed removal of intraocular foreign body resulted in high risk of endophthalmitis. Woodcock found that the failure of using prophylactic systemic or intravitreal antibiotics were associated with high risk of endophthalmitis. In their study, they used ciprofloxacin orally. The standard procedure nowadays is either intravenous coverage with antibiotics that cover both gram-negative or gram-positive, or if you don't have that or don't have access to intravenous antibiotics, you can give moxifloxacin orally. The Knox study found that in a study by Knox, they found that immediate injection of intravitreal antibiotics with delayed removal of the foreign body in eyes that present with endophthalmitis and retained intraocular foreign body is a possible alternative to immediate removal. And this can be applied in cases that it is slightly difficult to operate on, as the case I showed earlier. And as the time presents, time from primary repair to foreign body removal presents a challenge. I brought the foreign body secondary to gunshot wound as an example. So in patients with the gunshot wounds, usually if they had the foreign body, they will take time until they can reach a tertiary eye hospital and remove the intraocular foreign body. This has been studied by Ghuraba et al., where he included 103 eyes. All were injured in the Iraq war. And the mean duration from primary repair to vitrectomy was 3 weeks. And despite that, they had slightly good outcome with a mean final visual acuity of 20/400, and the visual acuity improving in around 60% of the patients postoperatively. In their study, all complications were related to the original injury, like macular scarring, puckering, recurrent retinal detachment, subretinal fibrosis, consecutive optic atrophy, and proliferative vitreoretinopathy. And despite the delay, there were no cases of phthisis bulbi or sympathetic ophthalmia. The other study looked into delayed removal of foreign bodies by Thatch and Bajer, where they found that in foreign bodies secondary to explosive trauma, it's not mentioned here, the average time to removal was again 3 to 4 weeks. And it often results actually in multiple foreign bodies. These foreign bodies are usually globular and smooth. And as Thatch mentioned, there is usually a delay in removal of the intraocular foreign body. And initial retinal detachment, perforating trauma, and endophthalmitis in such cases suggest a bad final prognosis. Coming to the studies that has been published within our region, this study published in 1998 by Dr. Abul Asra and colleagues retrospectively reviewed 96 eyes with intraocular foreign bodies over a 6-year period. They included 63 eyes, and the final achieved visual acuity was 2200 in around 65%. 9 eyes only had inoperable retinal detachment at the end, which represents around 9%. And they found that rheumatological retinal detachment after posterior segment foreign body is associated with a poor visual outcome, obviously, and that the larger the foreign body and the presence of endophthalmitis are the strongest predictive factors for the development of rheumatological retinal detachment, as we have mentioned earlier. The same group looked into the visual outcome prognostic factors after vitrectomy for posterior segment foreign bodies, and found that delayed removal of the foreign body following trauma may result in a significant increase in the development of clinical endophthalmitis, and that risk factors for poor visual outcome may include poor initial visual acuity, posterior foreign body location, and no vitrectomy at the time of foreign body removal. A study from King Khalid Eye Specialist Hospital by Imtiaz Chowdhury and his colleagues looked into the incidence and visual outcome of endophthalmitis after foreign bodies, after intraocular foreign bodies. They reviewed 590 eyes with intraocular foreign bodies over a 6-year period, and found that the corneoscleral entrance wound, the uveal prolapse, and the development of retinal detachment were predictors of high risk factors for endophthalmitis, and thus predictors of poor visual outcome. This talk is a broad guide for those interested in intraocular foreign bodies. The topic is too big to be covered on one grand round. The role and types of prophylaxis, the tools and the choice of techniques for removal of intraocular foreign bodies were not covered in this talk. So in conclusion, risk factors can be used to inform the visual prognosis and plan prompt surgical intervention for the patients. Causes of intraocular foreign bodies were mostly work-related and could be preventable, as we have shown that, and as you know now, that most are metallic and most are affected are men in their 30s. Education and activation of using appropriate protective safety glasses during work are necessary to avoid serious eye injuries and blindness. And that functional results do not necessarily match anatomical restoration if vital anatomical parts are impacted and injured. Thank you very much.
Thank you, Professor Marwan, for this very interesting topic. I would like to open the floor for questions or comments from the audience.
السلام عليكم.
وعليكم السلام.
This is Dr. Blushi. Allah يعافيكم.
Hello, Dr. Abdulrahman.
Thank you very much, Prof. Marwan, for a very nice presentation and summary. It was really very well presented, and you summarized the whole literature in this topic. Regarding I just want to touch a few points regarding the complications. As you described in the papers, that complications sometimes can happen from the direct injury to the intraocular structures by the foreign body. Other things can happen later on, like endophthalmitis. One interesting thing regarding some of the metallic foreign bodies like iron, there have been several papers describe the functional changes after immediate removal of intraocular foreign body in regards to the inner retinal dysfunction. So it will be very interesting to follow up with those patients after immediate removal of these foreign bodies with electrodiagnostic, including full-field ERG, and to see how those patients will behave during follow-up. I can remember one paper that described the adaptive optics imaging in those patients, which shows there was an even distribution of iron particles throughout the inner retina that lasts for up to 1 year. And the electrophysiology shows changes, including inner retinal dysfunction, electronegative ERG during the follow-up. I think it will be very interesting in the future to keep following those patients with the electrophysiology and to see how they behave in the future.
Yes, thank you, Dr. Abdulrahman, for this comment. True, that is absolutely right, that removing the foreign body does not mean the end of complications. And we have seen some patients who, especially copper, which is very toxic, after immediate removal, they still deteriorate in vision. And I remember one patient who has lost vision completely because of toxicity due to copper. It would be a nice study to look into them longitudinally and see how the electroretinal studies, ERG studies would get effective throughout time in these patients.
Very interesting. Professor Marwan, from your experience and from your review of the literature, what is the best approach? Is it to do primary repair initially with the antibiotics injections and then removal of the foreign body after a week or two, or to do the removal at the same time as the primary repair?
Yes. So as I have mentioned, it depends on many factors, including the presentation. I think it is always safe to close and then plan later for removal. Sometimes you will have the foreign body in front of you, just sitting there, or interlenticular, or in the anterior segment, then it is okay. But if it is in the vitreous, then you're risking it regarding is the view gonna be good or not? Are you gonna develop edema, corneal edema, in the middle of the surgery, and you cannot complete it? You cannot examine the periphery and make sure that you did a good vitrectomy and probably didn't miss anything of importance inside. Or so probably it is better to if you are afraid of the risk of endophthalmitis, you can just do the primary repair, close, and then schedule the patient later and inject, of course, intravitreal antibiotics, and then schedule the patient later after things are stabilized and the cornea is looking better for a secondary procedure to remove the foreign body.
Yes, I agree. I think after we implemented the prophylactic intravitreal antibiotic injections in primary repairs with high risk, including the intraocular foreign bodies, I didn't recall having any case of post-traumatic endophthalmitis in King Abdulaziz University Hospital, but I'm not sure if it's the same with all of our colleague surgeons.
Yes, it's worth looking at.
Anyone else who has any questions for Professor Marwan? Anyone in the chat? Okay, so it seems everybody is happy. I would conclude this grand rounds and thank Professor Marwan for this very nice and summarized presentation on the outcomes of intraocular foreign body. And I will have to emphasize again the importance of prevention. In all these cases, they are young, unfortunately uneducated manual workers who, if they have worn safety glasses or goggles during their work, would probably have had a very lower chance of having these injuries, devastating injuries to the eye. So it is always important to emphasize on these people in the workplace and ask also probably like the companies who employ them to implement safety measures to protect them and protect their eyesight from these devastating injuries. Thank you very much for everybody for attending, and we will rejoin for the weekly quiz in a few minutes.